I'm Lindsay Browning. I am the Director of Medicaid Programming at the National Association of Medicaid Directors, and it's great to be back as your host for the Crisis Jam today, episode 151. We will be featuring, as I said, crisis services in rural regions of the country today, and hearing from Dr. Billina Shaw and Bethaney Myers from SAMHSA as our featured presentation. Before we get to our feature, we always like to remind folks where you can access all of the incredible materials and past recordings from the Crisis Jam. So if you go to talk.crisisnow.com, that's where you can view previous recordings, materials, you can sign up for the newsletter, etc. So sign up, share this with your friends. It's a great resource. And of course, last week's Crisis Jam is up there right now. You can see the presentation from Dr. Tia Dole at Vibrant. So I encourage you to check that out if you weren't able to join us last week. We love to continue to feature our top 5 of all time. And of course, number 1 actually features today's speaker as well, Dr. Billina Shaw, on our special edition on youth crisis services. But encourage you all to check those out. You can scan the QR code and get to the YouTube page. Next slide. All right. If you didn't hear this plug before the top of the hour, the Crisis Jam is looking for your ideas. Over its history, nearly 400 unique speakers have been featured, but we are looking to you, the national community of experts on crisis services, to share your ideas of who would be great to feature in the Crisis Jam. Great topic, great speaker, etc. So you can send that using the link in the chat and submit your great ideas. Next slide. So I want to feature a couple of news articles this week. The first is from NOLA.com, really looking at how others in the community, particularly youth pastors, are starting to become first responders to the mental health crisis among youth. I think really speaks to the fact that responding to this crisis is an all hands on deck effort, and really looking outside of traditional providers to be those frontline responders when individuals are in crisis. The other article we wanted to share is around how healthcare workers are also facing a mental health crisis, really looking at a CDC report that just came out. So I encourage you all to check out that article as well. And then finally, want to flag for folks that the Lifeline awareness videos are available, including a new video that looks at ASL, American Sign Language Services, and 988. Next slide. And then we want to flag the SAMHSA store. As always, this is a great place to get resources, materials to promote 988 to the folks in the communities you're working with, stickers, magnets, etc. So be sure to check that out. And then the Crisis Jam store is also available. You can get great t-shirts there and hats, but the great way to get your own 988 shirt through the store is to sign up for the Trivia Hot Seat. Karen is always looking for folks to sign up for that, so encourage you to raise your hand. I promise it's not too scary, as we will demonstrate. So let's go ahead and shift to the hot seat today. I want to welcome Wayne Lindstrom, who is the VP of Business Development and Consulting at RI International. Wayne, thanks for being in the hot seat today.
Well, thank you for the invitation. I figure David's probably going to throw me a curve here, so we'll see.
We'll see. Okay. So each year, Becker's Hospital Review tracks the number of emergency department visits seen by a single facility. And they share the top 50 by highest volume. So Parkland Health in Dallas has led 3 years running with 226,000 ED visits in 2022. Of these other top 50 from the 2022 listing, which had the highest utilization? Mass General, which is in Boston, Cape Fear, which is in Fayetteville, North Carolina, NYC Health, which is in Brooklyn, New York, and Wellstar Kennestone, which is in Atlanta perimeter. And we have the poll up if you want some help from the audience, Wayne.
Oh, I definitely will need some help because I haven't the vaguest idea.
I know it's a little bit of a shot in the dark here.
Well, I certainly could think about density of population, but I figure that's too easy. So we'll see what the audience has responded with before I respond.
And we have one more slide that may give you another data point too before you pick your final answer. But here's what the audience is saying. Mass General seems to be the consensus, well, slight consensus with 36% of folks, followed by NYC Health, and then the other two. But this slide here may or may not help, but it gives you a sense of population by metro area. So Dallas-Fort Worth has about 6.6 million folks in it, Boston 4.3 million, New York City 8.5 million, Fayetteville 355,000, and then Atlanta we have 6.1 million. So what do you think is your answer?
Well, it seemed that New York was kind of the default based on population, but I'm going to reverse engineer this in my own mind and go with D, Atlanta.
All right, can we show the correct answer? Okay, it's actually Fayetteville, North Carolina, Cape Fear. And part of it is the way emergency services work, and that Fayetteville is serving kind of a larger geographic area and is the primary facility for 1 million folks living within a 50-minute drive. So I don't know if you were surprised by that.
Well, you know, I didn't reverse engineer it enough, apparently, but I understand I still get a shirt. You still get a shirt, and that's why folks should volunteer for this. It doesn't matter if you're right. We just appreciate folks getting in the hot seat. Wait, thank you for joining us for this. All right, thank you. Bye-bye. All right, so shifting gears to our quote of the day, and I think this fits nicely into the topic we're talking about, which is crisis and rural services. The full scope is overwhelming. Help others see the baby steps. And really, truly, we're talking about how do we see the baby steps in this massive challenge of making sure crisis services are accessible to folks in rural communities. So with that, I am going to turn to our featured presentation today and welcome Dr. Billina Shaw, Senior Medical Advisor in the Office of the Director at SAMHSA, and Bethaney Myers, Public Health Advisor in the Division of State and Community Systems Development at SAMHSA. So Dr. Shaw, I'll turn it over to you.
Well, I'm so glad to be here. I believe my current career highlight is being the top viewed co-presenter on the Crisis Jam thus far, and I'm so glad to do this. I'm a touch under the weather. My voice probably sounds a bit different than usual. And my co-lead, Bethaney Myers, is even more a touch under the weather, but say hi. We were just chatting that we work together as a team, and that means that when one of us can't speak, then the other one does, because she has no voice. But I want to just acknowledge that all of her work and dedication to this project, and we have enjoyed it so much. So I am a psychiatrist, as I said before, child, adolescent, adult, and addictions. And I'm also, before I came to SAMHSA a little over a year ago, I worked in local government, and I was working on building out our crisis continuum. And that it was definitely that build the plane as you fly, and it's still a work in progress. And before Bethaney came, she worked directly in mobile crisis. So we got a bit voluntold to work on this policy academy. Next slide, please. We've been, both of us probably asked at one point, what is a policy academy? And I'm sure you're wondering what that is too. And today we'll talk a little bit about one of the events that we had this summer at SAMHSA. So a policy academy is really, this is the first part of it where there are presentations from experts. And then there's later on an exchange, and it's in between the experts and the exchange of the teams that they develop a plan around a topic. So next slide. So today in this presentation, we'll talk a little bit about the goals of this policy academy specifically. the structure and outcomes and the follow-up of the Policy Academy. So usually policy academies at SAMHSA are focused on states or state level presentation or events. But this one, we wanted to focus on counties, primarily for some of the reasons that were seen in the pre-show around the fact that when you look at often like census tract level data or even county level data, you can see disparities, especially, for example, in suicide, deaths by suicide, that you can see disparities. And so we just want to make sure that we're looking directly to where the need is, and then also knowing that communities know their own need better than anyone else. And so when we think about developing a crisis system, that system has to be developed with knowing how to be directly responsive to the needs and making sure that the community is highly involved in that process. Next slide, please. So our goals were really to identify the current pathways and gaps in the current crisis systems in these targeted communities, increase access to appropriate care, and close those gaps. We're doing that by building system capacity and increasing interagency communication and collaboration. And then finally, we did this all founded on evidence, you can keep going, on the evidence-based practices and policies. And so our participants, there was three main categories of team members. Next slide, please. And the first one were local teams. Next slide. So the local teams were selected based on participating in the SAMHSA service members, veterans, and their families, technical assistance, crisis intercept mapping workshops in the past. We felt that those groups would have the capacity, and this was really a stepping stone in growing this work beyond their veteran populations. And then we wanted to really identify rural or remote communities. When we think about the crisis guidelines and the needs in communities, a lot of times rural and remote communities have more challenges in being able to implement the guidelines as they are. So we really wanted to really think about geographic equity in this way. And so we then took those, we can keep the back slide, please. So we then also looked at regional representation. So we wanted to make sure that we touched all the HHS regions as much as possible based on the cohort that we had. And then we were thinking about equity and making sure that we selected, initially, next slide, we selected tribes as well as a territory, and we were able to include a territory in our work. Next slide.
All right.
Yep. So, yep, you're good. So there were 6 rural remote local teams. And here's a list here. The key things to know is that one of the teams was actually a regional collaborative of counties, and one was a territory. And we just, being a regional collaborative, we thought would be something that would be common in some communities where the networking of resources to really build up that infrastructure would be essential to build out a crisis continuum. Next slide. So the potential team members here really ranged between state public health, public behavioral health leadership, people with lived experience, also local officials, law enforcement, behavioral health providers, tribal representatives, your hospital and detention center representatives. I mentioned. So I love this picture because it's a picture of in Texas. They had their goal here, and they not only had law enforcement at the table, but as a true equal voice. And you can see he actually did the report out. So he has his badge and gun right there, but they're all bought in to the importance of behavioral health systems development. Next slide. And then the experts. Next slide. Our experts covered a ton of topics. You'll probably recognize several of them from the JAM. That between crisis systems and modules, state, local leadership and coalition building. One of these things is that I want people to know that in their own local communities, they can be leaders, and that you have a voice, and that you can be a change agent. Crisis system financing, data and evaluation, law enforcement 911 connections, workforce, rural crisis services, equity and lived experience and youth services were all topics that were covered within the modules. In our next slide, experts were, you can see here, many faces, both federal and non-federal experts, ranging between the public sector and the private sector, but really focusing on the multiple array of these topics. Thank you. Next slide. And finally, SAMHSA staff. We staffed it and participated in the event. So the 3 pillars of the crisis continuum, someone to contact, someone to respond, and safe place for help, were really the foundation of the goals that they built. Next slide. And as part of this, we built these goals. Is that in the mapping exercise, we didn't do some fancy map with software. And we really just said, let's take a day of the life of somebody in your community. And if they called, say, 988 or another local line, how would they get to access crisis services, and what are the strengths and weaknesses? We wanted to make sure that also this hypothetical scenario included somebody who was at high risk for suicide and also was experiencing substance use disorder, I believe some intoxication and withdrawal over the course of this hypothetical exercise, to make sure that we were inclusive of that. And then we also wanted to make sure that the youth experience was considered in the exercise too. Next slide. So here are just some pictures that highlight that we went from the big room to eventually going into breakouts. Next slide. And I love this picture because we ended up being in hotel rooms. It was quite a busy in the hotel, but the teams labeled their doors, and you'll see our own Brian Sims there, working with the U.S. Virgin Islands, Brandy Jean Titus there, working with, I think that's Walla Walla, Washington. Next slide. So common goals and objectives, really, I'm not going to go through the entire slide, but really between increasing awareness, the needs of responding to the needs of youth in a timely way, establishing community champions, finding more funding, improving relationships between behavioral health and law enforcement, identifying the gaps in the crisis continuum even further when they went home, further training and education, especially related to substance use disorder, and looking at how to implement better technology or better use in technology in the system was important. Next slide. So, and actually we asked each team to focus on a pillar, and they could select more than one pillar, but it was really evenly distributed. And I was actually somewhat surprising, because we know that the receiving center element of this, which is encompassed in the safe place for help, can be harder in rural communities, but many still were focused on that. Next slide. So I love this slide here. We did some Mentimeters and talked about how do you feel about your plan, and had them put it up on a slide and text it in. Supercalifragilisticexpialidocious is one of my favorite ones, but hopeful, better informed, encouraged, but still some of them, taking one step at a time, and some of them were cautious too. So it's not the whole, but have a lot to complete. But nervous and tired, it's a lot, and so we honored that. Next slide. And so, when you think about building on a crisis system, and not just, a bunch of services, but developing a system, it's a lot. We were, I think, a bit stressed and, and working through this, even planning this policy academy, because thinking about the breadth of crisis care can be, and distilling it into a couple of days can be so important. And then, so what we did was we said, you pick 3 goals and 3 objectives, and that's all. And you take those 3 goals and 3 objectives, and you go back and, vet it back with your home, additional team members, et cetera. But let's just stay at a very high level and go from there. And most of the teams really had goals that were around collaboration as well. But this team A here, we just left it vague. They wanted to expand their existing mobile crisis by expanding their hours of operation, and using local colleges to recruit was one way of doing that. And they've been reaching out, and they've actually set up a lot of that infrastructure, and they're soon to go live with that expansion. Next slide, please. Another team B, they really wanted to focus on that stakeholder engagement And they have gotten some buy-in and commitment from other sectors. And this is, and especially in rural communities, we think that it's so important for that to go to that systems level, because when it's a small community, it can be so person-to-person relationship driven. And that is not a system. And if something happens to somebody, then you have you have then disrupted your service continuum. And then also, there's also the issues around confidentiality, and that can be a concern as well. And when you develop a system, I think that some of these things can be mitigated. So this team was really looking to procure a vendor for a local lifeline call center technology to really better integrate their work. And they're working on getting accredited to be added to the Lifeline network. This is and also they're also looking to increase awareness of 988 in preparation for this, because this local community did not have the calls being answered within their own jurisdiction. Next slide. And then the third is obtaining additional technology for crisis continuum for Team C. And they were reviewing their police department records and calls, et cetera. And really wanted to focus more on data and making sure that their work was being data driven, which we strongly suggested and had a whole segment on data. And the progress and the progress for them thus far has been that they've been working through the approval process for really the integration of the crisis care technology. They've been providing extra training to their police officers, crisis response, and they actually secured funding for crisis stabilization services as well. So we met with a good number of the teams recently and just had a follow up, and we're looking at doing, next slide, more follow up with the teams in the future too. So far we've heard that there are some barriers to integration of technology, and moving from that individual model to systems level model can be challenging. The 911 and 988 integration is an uphill battle that a lot of communities are struggling with. But they were really excited, enthusiastic, and we were planning to offer them some follow-up in the form of something like a learning collaborative and continue to work with some of the subject matter experts. And they're all very excited and thankful. So, when this was iterative, this was our first, I think it's the first policy academy that we've had at SAMHSA that, next slide, that has been focused on local communities. But we also just know that sometimes people say that SAMHSA doesn't focus on the rural communities, concentrates services or funding in certain areas, and we wanted to eliminate that and really think about how, or at least that misperception, and also target the communities that are greatest in need. And we're really excited to continue to work with these. And we just feel like this has been a catalyst for many of them who have been doing the work already. And also the attention from SAMHSA has been able to garner sometimes attention from their state leaders in a way that they might not have felt that they had the same degree of access to their state leaders in the past too. And so I'm really helping them to better strengthen their relationships between the state and the local communities. So we're just so excited and thankful. There's Bethany and I, when we both had voices and weren't clearing our throats every 30 seconds, but next slide. And that's the end.
Dr. Shaw, thank you so much for sharing that incredible work, particularly in spite of feeling under the weather. I know how tricky it is to speak when you're not feeling so great. If I may, I'd love to just ask you one quick follow-up question before we shift to our roundtable. And actually maybe it's two parts. Was there anything that kind of particularly surprised you coming out of the policy meeting, and one thing that maybe you were most excited by?
Sure. I think the thing that surprised me the most was that the degree of that, with that safe place for help, and the way that the national guidelines are written with that crisis stabilization unit for the adult guidelines. It's a pretty rigorous model, and I thought that many communities might shy away from that, but that they were still really focused on finding a way to meet that level of care or get really close. And so I think that was, just surprising that people weren't shying away from it as much. And what was the other question?
Anything that one thing you were most excited by coming out of it?
And the most exciting thing, I think, was really just the seeing the teams get together and network. When we ended up flying them out to Baltimore, and just being able to see the teams be relaxed and comfortable with each other, and being able to grow and bond and build some relationships that I don't think had existed, even if they were still, coming from a local community, was really important. And I've also been just excited to see the progress of the teams that we followed up with, and just how much work they've done thus far. And we just think we are just a little bit of an incubator for the work that was already going on. So just excited to see that.
That's incredible, and I think so well stated, the commitment from these rural communities to find creative ways to meet the standards, right, and build the capacity needed is just phenomenal. I'd love to shift to our roundtable now and invite our three roundtable experts to come on and offer their reactions to Dr. Shaw's presentation. So Ivory Tubbs is a technical expert lead at the Western Interstate Commission for Higher Education. Dr. Brian Sims, of course, from NASHPID, and Ron Manderscheid, who's the principal at Capstone Solutions Consulting Group, and a professor at Hopkins. So I'd love for the three of you to join. And Ivory, maybe I'll go to you first to share some reflections.
Thank you. Thank you, Dr. Shaw, for presenting. This is healthcare in rural areas it's something that is not easily overcome. I worked with HRSA on the Rural Communities Opioid Response Program, and one of the biggest things is not always access to care, but it is having the care to have access to for some of them. A lot of times we found out during the pandemic that people had telehealth platforms, but they weren't tested. Pandemic happened when they found out they may have had some issues. One of those issues became broadband connectivity. I think when we're talking about healthcare in rural areas, the need is great, but a lot of times some of the organizations in rural areas who want to provide the services, they don't have the bandwidth. They don't have the personnel. And when they do get an applicant, they have to greatly incentivize that position to pull that person from an urban area to come out to the rural areas. There are no level 1 and level 2 trauma centers in those areas. So I appreciate the presentation because it shed light on a lot of things. We all stay in our little silos here and there, but at the same time, there's a broader issue at hand, and how to give people in rural areas better access and better care.
Brian, what are your reflections? What would you add?
Well, not a lot to add, except to add excitement in one sense, that with SAMHSA's vision and how they looked at this whole process just excited me to no end. I was very honored to be a part of this process, because what it was doing was something that NASHPID has been working with the various states on, and that is really kind of getting a gauge of what the needs are for the various states, understanding that one community is one community. So we had this opportunity then to explore things where there was a give and take for each area. They could all hear positives, they could all hear challenges. It was just a wonderful setting to be in. And I just applaud SAMHSA's vision for looking at it as a policy academy, because I've been to several other policy academies, and this is the best way to emphasize the point that Billina had made a little bit earlier about communications with the communities, because they know their needs better than anyone else. So it gives the format of being able to pull everyone together. I was particularly intrigued, and the takeaway for me was really the affiliation, not just with the communities and with the law enforcement otherwise, but even with our international friends, or we had a large coalition from the Virgin Islands that were there and presenting their unique perspective. So it gave everyone in the room an opportunity to talk about what it is that could really propel it forward. And lastly, I'll just say that there was tremendous interest and investment. And I think that this is the lifeblood that continues these policy academies. So again, applause to SAMHSA for the vision, and thank you, Billina, and thank you, Bethaney, and all of the folks that were involved in the process.
If I may, I would love to ask you both a quick follow-up question. You know, I think the use of technology in rural communities and thinking creatively about how services are delivered feels important too. Do you guys have any reflections on opportunities to think differently about technology and crisis services in rural communities?
Dr. You go first and I'll go.
Okay, all right. Well, actually, a couple of takeaways was that understanding that in many of the rural communities, technology access is fairly limited. What we see is that there's a lot of creative measures that can be done that don't involve a lot of technology input. Such things as some communities looking at direct contacts through utilization of their faith-based initiatives, or looking at making connections through barbershops or beauty salons or otherwise that provide that conduit where trusting members of the community are chosen and then can have this positive impact on one another. I look at the Virgin Island component, and their thing was looking at mobile crisis, just taking a look at having mobile vans available to go out to the communities, connect, collaborate, and empower.
Yeah, I want to piggyback some of that. Go ahead. Did you want to say something, Lindsay?
Oh, I was just going to reflect that. I think that notion of relying on trusted community partners and maybe different community partners than you would in a non-rural community is a really good point. But Ivory, please.
Yeah, just to piggyback, the mobile units, those are huge. You have a lot of people who will not, and I have a facility, a hospital that I spoke with, that they got a mobile unit, outfitted it, it was great, but people were still reticent to come. I think post-pandemic, there is still a little bit of stigma associated with seeking healthcare, especially in rural areas. And with the advent of, like I said, telehealth, like Dr. Smith said, is, having access to it is a huge issue. I've had people tell me that they will offer out an iPad and have someone drive to the library and have their session or go through whatever issues they were going through and talking to a therapist and things of that nature. So, I mean, right now we have to use as many creative ways as we possibly can, because again, just that connectivity is an issue. It's a huge issue. And also people in rural areas actually don't have a lot of smart devices. So we've got to look at how we can take services to them.
And that actually, just to jump in, I think that in Oklahoma, we had, Jeff Hunter, who is really one of the visionaries behind that Oklahoma iPad program, really getting individuals in the field connected to crisis clinicians. And there's multiple layers of that program. That could be a whole presentation on itself. But one thing that I really took home from that is to making sure that we're utilizing the technology in a way that is efficient and that we're maximizing the use of our workforce with, say, telehealth and getting a mobile crisis clinician connected, if they're not on the field, not in the field. But we also don't want to take away the sense of safety and security and burn out the individuals who are still possibly in the field and mobile. And so that when there are those trade-offs and there are those allowances for deviating from, say, a 2-person team, because of the workforce shortage, that we do want to make sure that we're not overburdening someone and then continuing to churn through our workforce as if they're not people. So yeah, I think that it was just a really good highlight for me of the need for that balance between making sure that we can increase the efficiency, but connecting people as well.
And I don't think we have Dr. Vanderscheid on, but Ron, if you're here, please feel free to jump on camera. But maybe I'll just ask the two of you kind of one closing question, which is, for those of us who are maybe working in the crisis space or adjacent to the crisis space, but haven't spent a lot of time on sort of rural crisis services, kind of what's one piece of advice you would leave folks with who are doing more and thinking about rural crisis services?
All right. It would be for me a reiteration of something you've heard before. If you're going to go into communities, make sure that you are a very good listener as opposed to a promoter. Communities are quite often much more receptive when you come in and speak to them in a lens that says that you value what it is that they have as far as ideas, as far as what it is they want and the speed in which they want it. To go in and push your issues tends to have very negative or poor outcomes. So just be good at being empathic and being good listeners.
I would agree. I think I've told many of my grantees of hospitals that I work with, before you launch, be sure, one, that you're offering the services that they need, not just pushing your agenda. And then secondly, launch slow. Make sure that you have all the T's crossed and I's dotted, because you don't always get a second chance at gaining their trust. So I think, to what Dr. Sim said and some others maybe in the chat, we've got to make sure that we are giving them the services that they need, even though we may see trends and things of that nature. Sometimes it's just about getting in. And once you get in, then you can really start to administer the services that you know the community needs.
I think those are phenomenal words of wisdom of go in and be an incredible listener and be sure you're offering what the community needs so that you don't miss an opportunity to gain trust in that work. So thank you guys. Thank you both so much for your incredible reflections and your leadership in this space as well. Just appreciate the discussion.
Thank you for having me.
All right, we'll go ahead and shift gears now from our feature to our standing updates. And I'm actually going to welcome Dr. Shaw back for our SAMHSA update this week. Dr. Shaw.
Thank you. That's what happens when the 988 team is also on a site visit as well, even though I'll be doing some regular updates. So the main two updates that I have are related to the mental health block grant. So number one, the mental health block grant applications have been are under review right now, and the teams are seriously considering all of the requests made by the state. So you should be hearing about that soon if you are either a state, a mental health agency, or also receiving funding through the mental health block grant. The other major initiative that I would love to highlight a little bit more that is part of the mental health block grant is the Transformation Transfer Initiative, or the TTI projects. I think there are so many opportunities for communities to receive SAMHSA funding and SAMHSA support and technical assistance that are not always well highlighted. And I'm here for about a year and just learned about this project last year when I've come, but there are really many pilot incubator grants for about $250,000, and they will be announced next week. So I'd love for NASHFID, who administers these funds on our behalf, to really bring together some TTI grantees in the future and hear more about what they've done. But what's really exciting is that the last several years of these grants have been focused on crisis services because of the set aside. So this year's topics for the TTI awards, they're topically grounded for each cohort, are establishing same-day or rapid access to behavioral health care for crisis prevention and follow-up care, state strategies to improve the capacity of the behavioral health care workforce, improving access to supported employment for transition-aged youth, crisis and suicide prevention for high-risk populations, including Black, Indigenous, and people of color, American Indian, Alaska Native individuals, LGBTQIA individuals, and individuals with intellectual, developmental, and physical disabilities, deaf, hard of hearing children and adolescents, and improving the interoperability between 911 and 988. So really all of these topics, you know, are core topics that are talked about in this group. But I would just continue to make people aware that these are opportunities that can be available through an application through your state process. And this year's will be awarded soon. We are piggybacking off of some of the work that's been done with the policy academies to make sure that communities can continue to grow and build. And that's not kind of a one and done with our work. And after this year, continue to see another cohort and what they're doing.
Wonderful. Thank you, Dr. Shaw. Hopefully you can go rest your voice now, but appreciate those updates as well. All right, let's shift to NASHPID for their weekly updates, and I'm going to turn it to Christy Malik for this week. Christy.
Great, thanks, Lindsay. So, and Dr. Shaw, thank you so much for highlighting the TTI grants. We really appreciate SAMHSA's support just with that little bit of money that can really help make the difference to communities and implementing some innovative strategies. So I'm going to highlight a couple of resources, kind of keeping with the theme of rural services. If we go to the next slide. Great. As you kind of see, we kind of revamped this slide to really illustrate states that have been highlighted on past crisis jams. And we really hope to focus on some of the amazing work that other states are doing that have not yet been highlighted. So again, we look forward to highlighting some of those states in future crisis jams. NASHPID and NRI partnered with SMI Advisor in developing a resource that really focuses on the behavior or addressing the behavioral health disparities in rural and remote areas. We convened focus groups and also we conducted interviews with subject matter experts that are serving rural and remote areas. From that, we were able to develop this resource, and I believe Kendra from SMI Advisor just put in the chat box the link that you can go to download this resource guide. And go to the next slide. As we were meeting and working with the focus group, one of the things that came out, some of the themes, and as many of you have heard, it's the 3 A's, and sometimes people say the 4 A's, focused on acceptability, availability, and accessibility. Those 3 A's seem to be kind of the core barriers for some rural and remote communities to be able to actually have behavioral health services in their areas. So we wanted to kind of take that back and say, okay, you know, working with the focus groups, what are some innovative strategies communities have done to really address those barriers when it came to acceptability, availability, and accessibility? So that was the framework in the way we outlined the resource guide. We also focus on, as we were thinking about strategies, we also focused on that social determinants of health lens as we were developing the guide. Next slide, please. So I'm just going to quickly highlight some of the strategies that communities have implemented. Again, as we kind of heard from Dr. Shaw's presentation and also from the roundtable discussion, you know, communities have come together and they've become very creative and be able to bring behavioral health services to their community for what works for them. So in the executive summary, we've highlighted some of these innovative strategies for availability, accessibility, and acceptability. So again, we encourage you to look at the resource guide. And again, there's some really great strategies that communities have identified. You know, as we were talking about telehealth, there's different ways that they've kind of embedded telehealth to really help support that community, and also being able to finance. That was one of the other key strategies, is how do communities work together and braid funding to really help finance mental health program and also sustain it. So then on the next slide. You know, and with the crisis jam kind of focused on crisis services and suicide prevention, I just want to highlight two sections within the resource guide. The first section is really focusing on crisis services, and the second one highlights some suicide prevention strategies that communities can implement. And then on the next slide. One of the key themes that kind of came out as we were working with our focus group and talking with subject matter experts was that there was this gap in really helping support peer support workers serving rural and remote areas. And again, we heard that sometimes they were the only behavioral health provider in their community. So again, we wanted to provide a learning community for them, for peer support specialists to come together and say, hey, you're not alone. So we're going to create this safe space for you to be able to share innovative strategies, be able just to talk and connect with other peer specialists also serving rural and remote areas. So again, for any of you all, if you know of a peer specialist that is serving rural and remote areas and they're looking to join the learning community, you can register here. The link is there. It meets the third Thursday of every month at 4 p.m. Eastern time. So, and again, it's really focused on peer support specialists or individuals with lived experience. So, and I believe that's all, and I'll turn it back over to Lindsay. Thanks.
Wonderful. Thank you, Christy, for sharing that work that you all are doing, and really exciting with the peer support learning community. I'm sure that's going to have a huge impact on peers who are in that role and having that unique experience in rural communities. I want to turn next to our federal update, and Joanna Rosen is going to lead us in that from AFSP. So, Joanna.
Thanks, Lindsay. Yeah, so Sarah at Guide, she's not here today, but she and her team have put together a really useful legislative tracker for us to use. So I just wanted to flag that for everyone. I think it's going to be on the next slide and dropped into the chat. So just wanted to remind everyone that that's here to stay in the know on federal legislation that revolves around the crisis continuum. Other than that, the Senate Finance Committee held a markup this morning on some mental health and substance use legislation. We did expect there to be some crisis care talk and potentially amendments that might make it through. I know for sure there's one Medicare reimbursement for mobile crisis amendment that's being considered. As the hearing started this morning at 10 a.m., we'll have more information on how it all rolls out shortly, and we'll keep an eye on that. Finally, on the federal budget front, the continuing resolution, the CR, that has been keeping the government operating since the end of FY23 is set to expire on November 17th. We can really never be sure of anything anymore, but what I'm hearing is most likely we'll probably see another CR maybe through January, and then hopefully Congress will be able to come together to finalize a full FY24 budget, but please don't quote me on this, given the new speaker in the House and the sort of ever-evolving dynamics in Congress these days. Trying to predict anything at all is really nearly impossible. So we'll see. We'll keep you all updated as we learn more. Hopefully we'll see more next week. Definitely we'll know a little bit more next week. That's all I have for federal updates for today. Thanks for tuning in, and Lindsay, I'll turn it back to you. Thank you.
Absolutely. And again, on this slide, you can see the federal legislation tracker that Joanna mentioned, and it's in the chat as well as the link to access that. And here's just a quick view of what it looks like. Hopefully that'll be valuable for all of you who I know have 10,000 other things going on and sometimes find it hard to track all the activity in Washington. So certainly check that out. Next slide. So I want to take a moment to preview the crisis talk, which is actually going to be next week, but this article is up now on the talk.crisis now website. And it tells the story of Iden Campbell and really kind of the work of rebuilding after a suicide attempt. Very powerful story, and would encourage you guys to check out the article. And next week we will have Stephanie here and Iden here to really talk about the article in more detail. So encourage you all to tune in for that. Next slide. So I am pleased now to turn to Vic Armstrong for our Strong Talk segment on race and equity and crisis care. Vic?
Thank you so much. When we consider I do love that theme music. When we consider the many challenges that humanity has endured over these past several months, in America with mass shootings, racially motivated hate crimes, and political division, but also abroad with full-scale war in the Middle East, we can often find it difficult to hold on to hope and social connection, the cornerstones of mental well-being. We're often faced with pivotal points where we must choose whether to put our heads down and persevere, or to lift our heads, steady ourselves, and stand firmly. As caregivers and leaders, these choices can be very difficult. Equity demands fairness and impartiality. But fairness, impartiality, and even justice are often viewed differently depending upon your perspective. What is not in question is that humanity matters. And while will always be pain and suffering among us, there will also always be champions and healers, many of whom now hear these words. While we do not take up arms or march into battle, we fight the good fight each and every day, trying to bring hope and healing to our piece of the world. Regardless of the challenge or weight of the moment, the one constant is that we endeavor to care for the hurting. Despite the presence of politics, personal convictions, or public opinion, we embrace those who seek a sense of hope. We each come to this moment in time with our own lived experience. We carry our own religious beliefs, political beliefs, culture, and heritage, yet we are all here in this space seeking better pathways to healing for those who experience pain and suffering. So I share these words with you in hopes that in the midst of the pain, the violence, the hatred, and the divisiveness, that we as healers of mind and spirit, stewards of hope, can rise above the noise and take to heart these simple words and pray that others would do the same. That I would choose to live and let live, love and let love, to show compassion toward and advocate fiercely for those who are less fortunate than I am, those who have lost hope and social connection. I will seek not only to see the good in others, but to compel the good in others. I will seek also to see the good in myself and offer myself grace. I will find joy in the moment and hope for the future. And I will leave the world a better place for my having been here. If these words, if these sentiments don't resonate with you, so be it. I urge you to find a place within your being where empathy, hope, and compassion live. And I urge you to linger a while in that place. And if you encounter those whose ability to express compassion is somehow muted due to anger, fear, hatred, or mistrust of the other race, the other culture, the other ethnicity, the other political party, the other religion, well, consider that perhaps they themselves have known immense pain. And that pain has caused them to lose a piece of their humanity. Offer them compassion and simply say, I'm sorry for your loss. And then stand with hope, stand with empathy, stand with humanity. And that is Strong Talk.
Thanks. thank you for such incredible words. And I think the hope that I feel even in response to your message is really incredible, and just appreciate, centering us on that important message.
Thank you.
Well, I want to shift us as we come to the top of the hour into a couple of reminders about what's upcoming. You can expect a fun and engaging Crisis Jam on January 24th, where we have another Crisis Jam debate on the really important issue of whether crisis services should or shouldn't come in a police car. And we'll be joined by Sabrina Taylor, who's a detective with the Phoenix PD, and Dr. Jen Struber, who's the Associate Professor of Social Work at University of Washington, to really dive in and have a friendly debate on that issue. Next slide. Coming up next week in the more immediate future here, we'll be joined by Colby Collin to talk about crisis services for Indigenous individuals. And then the week after that, in 2 weeks, we'll hear from Sanvi Aurora talking about the Youth Power Project. And again, we know there's been a lot of attention and interest in youth crisis services, so be sure to join for that. On November 22nd, hard to believe it, we're reaching Thanksgiving week, so there will not be a Crisis Jam that week, but we'll be back after that. And hope you all will be sure to join us upcoming for all of the great content. And again, be sure to share your ideas for upcoming sessions, topics, ideas that you would love to see featured in this incredible community of leaders who are doing the good work of building out crisis services and really bringing hope to people across the country and across communities. So thank you guys so much for watching. We look forward to seeing you next week. And in the meantime, be well and take good care. See you. Thank you.